Okay. If you have any questions, please put them in the chat box, or you can chat with Maria directly. Any other ways you want to do that, Maria?
Yes, if attendees prefer to send them directly to our presenter, Dr. Jones, you are welcome to do so, or you could send them to me and I will forward it to her.
Okay, and you'll have time at the end for questions. The way we normally do this is we save the questions for the end, because a lot of times the presenter will actually answer the question in the presentation itself. So, so on that note, we are gonna, we will have an online questionnaire that I will put on in the chat box as we get going. It's from the Alabama Council on Developmental Disabilities, who has been our funder. And it gives them feedback as to how beneficial the trainings are, and kind of impacts whether we'll get additional funding at another time. And this way too, we get feedback to see, you know, if you what you're learning, and maybe even if you have suggestions for other presentations. Yeah, and I'm going to put the yeah, and we're available in English and Spanish and Korean, right? Isn't ACDD also about, yeah, in Korean as well. And we are not going to have a questionnaire on just on this content. We are going to have just the ACDD links, and those will be toward the end when we go to the question and answer session. Dr. Christine Drew is with us on this grant that we were awarded from the Alabama Council on Developmental Disabilities, but she may be coming a little later. I don't think she's here yet. Doris Hill, I am an associate research professor and the director of the Regional Autism Network and one of the primary investigators on this grant. And then we've got Maria Gutierrez. Would you like to introduce yourself, Maria?
Yes, thank you, Dr. Hill. Good morning, everybody. First of all, happy holidays. I hope that you had a wonderful time with your families and friends. And we're so happy that you are joining us here today on this topic that I had a couple of parents reaching out and wanted to see if we could have a presenter. And so I was very happy to know that Dr. Jones was willing to come and present for our families. So thank you so very much. So for the ones that are new attending today, I am the family navigator for the Regional Autism Network. I am also a parent of a young adult on the spectrum, and we cover 20 counties. So we are the largest region in the state, and we try to assist families with the questions, concerns that they might have. So once again, thank you for being here so early in the morning during a Tuesday, but this is going to be a great topic and we hope that you enjoy it. So I'm going to pass the microphone to Dr. Jones. And Dr. Jones, would you like to introduce yourself? Thank you.
Sure. So I am, said Dr. Alicia Jones, I am an associate professor at Auburn University in the Department of Speech, Language, and Hearing Sciences. Primarily, I teach, do research, and I am in the clinic. Clinically, my specialty is central auditory processing disorders. And so you will see I may use CAPD versus APD interchangeably, and those are the same thing. So auditory processing disorders, central auditory processing disorders, those are the same exact thing. It really depends on what organization you're looking at on if they call it APD versus CAPD, but it's the same exact disorder. So can I go ahead and share my slides? Okay.
Yeah.
Let me. All right. So we are going to talk about APD today. And basically, these are kind of the things that I'm going to go through. first of all, I'm going to talk about how we hear, because that's very, very important on understanding how we hear and factors about hearing loss and how that plays into auditory processing. I'm then going to give us a good definition of what auditory processing disorders involve, as well as symptoms. And we're going to talk about diagnostic criteria, and that we'll even discuss really who's a candidate for the testing. And then I'm going to answer any questions you guys submit. So the big thing is, how do we hear? So this is a picture of an ear. So you'll see that the ear is divided into 3 portions. You have the outer ear, the middle ear, and the inner ear. So the outer ear involves your pinna, which is the part that you see on the outside, as well as your ear canal. So that's really what includes your outer ear. Problems that we can see in the outer ear a lot of times can be if you've ever had swimmer's ear, where you've had the bacteria get into the ear canal and the ear canal is inflamed. You can also have lots of earwax. So earwax is good. Most people think earwax is dirty, doesn't need to be there. And actually, earwax is actually good. It protects your ear canal. It keeps bugs out. The problem becomes if it accumulates so much that it forms a plug, and then that can cause problems with hearing. Then your middle ear has your eardrum. So it's called your tympanic membrane, but most people know it as the eardrum. And then you have your 3 tiny little bones. They're the smallest bones in your body, the malleus, incus, and stapes. And then your inner ear has 2 parts. It has your cochlea, which is that snail-shaped portion. That is your inner ear that we talk a lot about with hearing. And then your semicircular canal, so those kind of 3 rings, that actually works for your balance. So your inner ear involves not only hearing, but your balance. So this is how we hear. So sound is actually funneled. So your ear actually helps, the pinna directs sound in. Goes into your ear canal, and then it's going to vibrate your eardrum. And what happens is when your eardrum vibrates, it's then going to set off a chain reaction. And so then it starts, the little middle ear bones start moving. And then it also is going to amplify the vibrations. This actually amplifies about 30 dB here naturally. And then it's going to push and transmit those vibrations to the inner ear, which is the cochlea, that's actually filled with fluid. And that vibrations are going to cause almost like a traveling wave with that fluid, which then bends little inner hair cells. That's going to pick up that signal and transmit it up to the brain. So this is kind of a basic of how we hear. So sound is picked up, funneled into our ear, vibrates our eardrum, vibrates those middle ear bones, and then vibrates the fluid in the inner ear. That's going to cause the little hair cells to bend to be able to pick up sound. And what's interesting is our cochlea. So if you were to unravel it, different areas of that cochlea, that inner ear, pick up different frequencies. So as soon as you enter the cochlea, it focuses on like high pitch sounds. And then towards the middle is more of like mid pitch. And then all the way up to the top of the snail shaped portion is detects low frequency sounds. So that's, the cochlea is very topically organized. And so it is designated different areas to pick up different frequencies or different sounds. So when you come in for a hearing test, we graph it on what's called an audiogram. And so this is actually what an audiogram looks like. And I have one in English and in Spanish here. But you'll see this is actually what's called an audiogram of familiar sounds. And it kind of gives you, so if you look at the top with frequency or pitch, you have very low, so 125 low, all the way up to 8,000 high. Now, human beings, actually, we hear a wider range than that. We actually hear from 20 dB to 20,000 dB. So we have a very wide range of hearing. The only reason why we test the frequencies that are on the graph is because this is where speech occurs. And that is what we are focusing on when we're looking at problems hearing is speech frequencies, because that is what we're wanting to be able to amplify. That is what people are wanting to really have access to. And you'll see that we call this the speech banana, where all it kind of looks like a banana, the shaded area. This is where all of the speech sounds occur, at what frequency and what level. So from the top is very, very soft to the very bottom, which is really, really loud. And you can see in the middle where you have the two people having a conversation. This is where conversational speech happens, kind of in the middle frequencies and kind of in the middle of intensity as well. And you can see really loud, like an airplane taking off, jackhammer, going to a loud concert. Those are really loud. When you get really towards the bottom, this is where once you get above 85, the longer you're exposed to noise, the more likely you are to get permanent damage to your hearing due to noise exposure. So I like this representation because so many people think hearing loss is like vision loss, where you put glasses on and that immediately corrects your vision. There's a question. Oh, which one do I need to repeat? Sorry. I wasn't 100% sure what I needed to repeat.
Okay, let me ask for some clarification, Dr. Jones.
Okay.
Mr. Reed, is there a part that we need to go back a slide? Yes, please repeat the previous slide on the audiogram.
Okay. So with the audiogram, with the very top, so this is where we are going to, if you come in for a hearing test, this is where we plot the hearing test. And so the top is your pitches. Think about keys on a piano, how you have low pitch, high, middle pitch, high pitch. So if you've ever played, middle C is kind of that mid range. So this is very low frequency all the way to very high. And then on this axis here, the loudness intensity, you have very, very soft to very, very loud. And so you can see here in with the speech banana here, you've got what frequencies and how loud your actual individual sounds are of speech. And you have the two people talking here that are kind of at that conversational level. So this is where sound or speech is occurring. And then you have very loud sounds. So typically, if you're talking about 85 and above, so 85 up to 120, the longer you're around noise, the more likely you are to get damage to your hearing because of the noise-induced hearing loss. So that's why it's important to wear hearing protection. And I forgot on this right side, my right side, you'll see degrees of hearing loss. So you'll see where, typically 15 and above is going to be for a normal hearing for a child. We expect children to be able to hear better than adults. Then actually 20 and above is going to be considered normal for adults. And then you've got slight, mild, moderate, mildly severe, severe, and profound hearing loss. So we look at degrees of hearing. Many people think about it in percentages, and as audiologists, we don't typically deal with the percentages because the percentages is a medical formula that physicians use. And really for any type of like workers' compensation or other legal things, we look at degrees because degrees lets us know, gives us more information about your hearing loss versus a percentage. Because a percentage only actually accounts for about 3 or 4 frequencies, where you see we have way more on the graph. I hope that clarifies that. Okay, so I like this graph because this is something that when people think about hearing loss, they think about vision. And they think, oh, if I have visual loss, I put glasses on, immediately corrects vision. And that's not really how hearing loss works. And that's a lot because if you think about it, the ears are the pathway to the brain. And the brain is what really processes sound. So hearing aids that we do put on for hearing loss, they've come a long way. They help a lot. But at the end of the day, it's a broken system. And so you're always going to have some degradation, some, if you got these little hair cells that are kind of heartbroken, they're not picking everything up. They're only picking up parts. That's going to be transmitted to the brain. And so that's kind of what this represents as you've got normal hearing is kind of thinking of that normal Snellen chart that you see at the eye doctor. Visual impairment is all kind of blurred. Whereas with hearing loss, not everything is hearing clearly, but not everything is blurred. And there are different types of hearing loss. So you've got conductive, which affects the outer and middle ear. This is typically most of the time medically correctable. There are permanent conductive hearing losses, but most of the time we think of these as medically correctable. Usually a lot of times fluid, if you think about ear infections, having lots of wax, those things can cause a conductive hearing loss, especially you see a lot of ear infections in children. Sensory neural hearing loss, this is the more permanent hearing loss. This means there's either an issue within the snail-shaped portion, the cochlea, or in the nerve portion. So this is typically not medically correctable. This is where we're going to talk about hearing aids, or if it's significant, talking about more like an implantable device like a cochlear implant. And then you can have mixed. You can have problems in the middle and inner ear. So these are the different forms of hearing loss. Now, when we talk about auditory processing, again, going back to that whole concept of the ears are the pathway to the brain. And so what happens with auditory processing disorder is that you actually have normal hearing. It's how the brain is processing that sound. And you can see in this, you have the ears detecting, but we have lots of different parts of the brain that's actually involved in processing sound. And so that is why when we do a processing evaluation, it's long and intense because we're looking at all the different ways that the brain processes sound. Okay, so let's talk about what is APD, because sometimes there's some confusion on what it means. So I like this little picture because it kind of gives what the processing is. If you look at the very bottom, you have hearing sensitivity, and then kind of going up to your brain processing, cognition, so your understanding, language, and your thought process. Here, this is why with auditory processing, there's so much that is involved. And we'll talk about, there's a lot of different comorbidities. So there's lots of, most of the time, auditory processing disorders do not just present by themselves. I have been clinically doing this for 12 years. And I will say I have a handful of patients that I've diagnosed just with auditory processing disorders. They don't have any other diagnoses from other professionals. So basically this is, I have the definition of processing, auditory processing on the slide. So it's referred to as processing of auditory information in the central auditory nervous system. And what this involves is lots of different parts. So auditory processing involves auditory discrimination. Auditory discrimination is the brain's ability to hear sounds in speech and noise. So if you think about our world, we don't live in a quiet world. We live in a noisy world. So our ability to discriminate sounds and noise, these are important aspects. Also being able to distinguish, really fine aspects of speech, being able to just hear the difference between B and P. Those are very close sounds, being able to discriminate those differences. Then temporal processing, these are more fine aspects of speech. So looking at patterns, intensity, rhythm of speech. And if you think about it, we do a lot of inflection when we're asking a question or how we're emphasizing certain words. These are covering those type of aspects of sound. And then binaural processing. So our ears work together. We have two ears for a reason, and they work together to process speech and noise, to be able to tell where sound is coming from. So these are all like broad categories, but we do a lot of testing underneath each one, because with binaural processing, a lot of that is being able to integrate information together. So things coming from both sides, and then the ability to separate out. So being able to listen to a speaker, and if somebody were to come up and be having a conversation behind you, being able to ignore that and focus on the speaker. So this is something that you see a lot in the classroom, where a child is having to listen to the teacher, and maybe you've got some conversations going on behind them, and they're having to separate that out. Or a small group, a lot of times with elementary schools, you have the little small groups. And so you're at the table listening to a teacher, and then there's other activities going on in the classroom, and being able to separate that out. So ASHA, which is the American Speech Language and Hearing Association, that is kind of our main governing body for audiologists and speech language pathologists. They refer to APD as deficits in the neural processing of auditory information in the central auditory nervous system, not due to higher order language or cognition, as demonstrated by poor performance in one or more of the skills that I mentioned on that previous slide. So it's a very kind of broad term, but we're looking at, I would say, probably one of the main classic symptoms of auditory processing is acting hearing impaired, but not having hearing loss. So a lot of times these kids will struggle hearing in background noise. They'll struggle in the classroom. They'll ask you to repeat things. They'll say, huh, or what. They'll have a lot of difficulty hearing, but when you go to the hearing test, they have normal hearing. And that kind of goes into this next part of symptoms. So there are a lot of different symptoms, a lot of different characteristics that you could say could be auditory processing. You also see in this, I have this little wheel where you have a lot of different, there's a lot of overlap of auditory processing symptoms with other diagnoses. And again, like I said, in my 12 years, I've seen a handful of kids that just have an auditory processing diagnosis. Most of the time, there's other comorbidities, there's other things going on. And I'm going to talk a lot about attention, because ADHD is probably one of the #1 comorbidities I do see with APD. Sometimes ADHD, they may think is auditory processing, but it's really attention, but I'll talk about that in a minute. But this is not a exclusive to, not all these symptoms are exclusive to CAPD. not, and this is not an exhaustive list, but these are some strong characteristics on if a child is experiencing some of these, maybe an evaluation might be worthwhile. So I talk about ADHD versus APD because sometimes they have some overlapping symptoms. And it's really important to understand how attention impacts your ability to hear and your ability to process sound. I do a lot of counseling with parents on attention, because if you're not paying attention to the sound, to the speech, then there's no ability to process it, because you have to be able to first be attending to the signal in order to hear it and then process it. So my favorite example is if I am sitting at home watching TV and I'm really zoned into my show, and my husband comes in and starts talking to me. I'm so zoned in, I don't realize he's actually talking to me until probably he's already said a whole bunch of things, and then I realize he's talking to me. Well, I wasn't paying attention, so I didn't hear what he said. So I didn't have the ability to process what he said. So it's really important that you have a person's attention in order to process, you hear it to process the sound. So a lot of times attention has to be kind of the first thing that needs to be addressed if there are attention issues.
I have a question really quick. You're showing a view with 2 slides showing, at least on my screen, which makes it really hard to read. Is there a way you can switch the view so that people can see it better?
Is that better?
Yes, thank you.
Sorry, I didn't realize I had it switched. So yeah, so here are the ADHD versus APD. So you can see with ADHD, there's some distracted, a lot of times it can be hyperactive, or they could be inattentive, fidgety, restlessness, you'll see some impulsiveness. With APD, it's more you're having difficulty hearing in background noise, following directions. Usually we're talking about multi-step directions. So meaning, you know, you have go get your shoes and put them on. That's a 2-step direction. You have to go get your shoes as the first part and then put them on. Poor listening skills, academic difficulty, so they're struggling in school. And again, they can also be distracted. So that's not something that's just with ADHD, APD. So this is a more detailed list of what are the ADHD symptoms versus APD symptoms. And you'll see a lot of times with APD, they may mishear what is said, or they have trouble holding on to what was, like remembering what was said. But again, with ADHD, even if there is no ADHD, when we talk about good communication strategies with anybody that has hearing loss or a processing disorder, we talk about needing to get their attention first to make sure that they're listening before you start having a conversation. So causes, do we really know what causes auditory processing disorders? And really the answer is we have some suspicions, but there's no definite of what causes it. We know that if you are born premature, you are more likely to have risk factors for auditory processing, as well as other learning disabilities, like dyslexia, learning disabilities, ADHD. A lot of those you'll see. Prematurity is really my research interest in auditory processing disorders. Chronic ear infections from a child. So in the birth to 3 is when speech, language, auditory, all of that is, there's so much growth happening in that birth to age 3. If there is chronic ear infections, or really not just ear infections, it's chronic fluid. So the fluid is the problem. It's like you're hearing underwater. And if you have chronic fluid, sound has to be louder to get through that fluid to get to the inner ear. And that actually can affect how your brain develops hearing sounds. And so that's why having chronic ear infections is linked to processing disorders. We do know there's a lot of research, especially at the level of the VA, with traumatic brain injuries causing difficulty with auditory processing, and then neuromaturation factors. So a lot of times, there's so much growth happening, even up till high school. You see a lot of development happening. So sometimes it can be that the system is delayed. And you see that a lot also in preemies too. If somebody is born premature, it takes the brain a little bit longer just to kind of catch up. Okay, so diagnostic criteria. So criteria to test. Number one is having normal hearing. So you have to have normal hearing in order to do the testing. And you may ask, well, why is that? Our tests are normed on children and adults that have normal hearing. So all of our test criteria, if we're looking at what is considered within normal limits, what's considered outside normal limits, those are things that our test battery, all of our what we're looking at is based on people that have normal hearing. So meaning there's no hearing loss. So for us, when somebody comes to see me, either I do a hearing test at the beginning before we go on, or they have a recent hearing test within the last 6 months that lets me know they have normal hearing. If I do a hearing test and I find any version of hearing loss, I will stop because it will affect my test results, and I will not be able to accurately say, yes, you have auditory processing because there's a hearing loss. And typically we think about if you have any type of hearing loss, a lot of times those symptoms of auditory processing are very similar to hearing loss. And so the recommendations are not going to change based on the processing testing, if that makes sense. So we've got to address the hearing loss first. Again, the ability to maintain attention. So many audiologists will not, that test for auditory processing will not test below age 7. And that's because at age 7 is when it's really that the auditory system has, matured enough for us to test. We actually have tests down to 3.5 now, and I am able to test younger, with the caveat that they have to be able to kind of do the testing. So being able to maintain attention even with lots of breaks. So there are, if a child has significant ADHD, there is a test that we'll do for like auditory attention to see if they have the attention abilities to be able to do the testing. Because if they don't have the abilities of the testing, then all of my tests is going to show that attention is the main issue going on right now. And then participate in the testing. So being able to, a lot of our tests are verbal answers, and they have to be able to participate in the testing. So typically when I have somebody that has come here and I've done the hearing test and then I've done auditory processing test battery, typically the diagnostic criteria that I use are deficits noted in one or both ears of at least 2 standard deviations below the mean on 2 or more tests. So meaning that I do a whole bunch of tests to look at different areas, and 2 or more of those are considered outside normal limits. That would get a diagnostic criteria of auditory processing disorders. Typically a test battery are going to include these different categories. So we kind of mentioned like the broader categories early on, but you'll see that we'll do ability to discriminate sounds, patterning. We'll look at how they integrate, how they separate out. Can they tell where sound is coming from? Will make speech fast, will make it slower. How are they able to process that information? So these are different categories that we look at when we are processing, or we're looking at auditory processing disorders. And then there are some tests that you can do that you don't have to respond, and it's looking at putting electrodes on and looking at how the brain responds to sound. There is a newer test that we're looking at trying to add that looks at how the brain is hearing speech. It's something that we would use in conjunction with our behavioral test battery. We haven't added it yet, but our goal is to kind of get there. There's lots of different tests for using these electrophys, being able, this is actually what we use on little bitty babies to determine if they have hearing loss or not. But a lot of the research kind of shows mixed, whether it actually would say, yes, you definitely have auditory processing based on these particular tests. So that's why they're not utilized all the time with auditory processing testing. Usually it's mostly the behavioral test. So the test where we're actually having you listen to speech and noise and being able to repeat sentences back. Okay, so I was going to see what, there's lots of questions in the comments. So let me go look. Okay. Okay, so a question has a child has mild hearing loss in one ear, which can impact sounds. The question is, should they tell the school about it? Will the child need an IEP or a 504, and what's better for the child? So if there is any form of hearing loss, so we know that even with a slight or minimal mild hearing loss, it can actually significantly impact academics. Many times a teacher might not notice this because a child, especially for children that are not behavioral issues in the classroom, they may not realize how a child is struggling. So if there is hearing loss, I would say yes. Tell the teacher needs to be aware of that. Depending on your child, on how they're doing academically, would a lot of times with hearing loss, unless they're struggling in other areas, most of the time it's usually a 504 plan for accommodations. So one of the big accommodations we talk about with any type of hearing loss or auditory processing disorder is flexible preferential seating. So it used to be preferential seating was like right up front by the teacher. But in today's classrooms, we know that they're structured a lot differently. So we say flexible preferential seating. So if they're in a small group, they need to be closest to the teacher. If they're on the carpet, they need to be closest to the teacher. Whoever is the speaker, they need to be closest to the teacher. Okay, let's see. My child loves to wear his headphones to listen to music. Should I be concerned? He seems to love really loud music. So it depends on the headphones. So there are earbuds, and then you have, the kind of like the earmuff ones. The ones that go over the ears are a little bit better than the ones that go in the ears, only because if it's in the ear, it's closer to your eardrum. There is the kid headphones usually are really good about limiting output, and so that it's not going to be so loud for the child. But it is one that we do kind of just have to be mindful of. If you can hear it, then it's too loud. So if they're wearing headphones, they're listening to music and you can hear it pretty clearly, then that's way too loud. All right, let's see. My child was evaluated and there were deficiencies found in the area of phonemics. There are many programs. They informed us that these are methods and not curriculum, and that it should be scientifically based. Why is it important that they are curriculum and not methods? So there has been a lot of changes in the school system since the law that came into effect in Alabama on the Literacy Act, where all teachers have to be trained with like dyslexia training. And a lot of the curriculums or like the methods that have been added in are, I know Phonics First is a really big one, and that is a OG type method, so the Ortho-Gillingham type method, where they're really looking at.
I'm sorry, can you repeat the question?
Oh, the question. My child was evaluated and there were deficiencies found in the area of phonemics. There are many programs, but they informed us that these are methods and not curriculum, and that these must be, or it should be scientifically based. Why is it important that they are curriculum and not methods? And the difference, honestly, is curriculum is usually what the school is using. But many of these programs are geared towards phonemics since that literacy law came into act, at least in the younger grades that I'm familiar with. I believe you are going to receive a copy of the slides later. Okay. Is it possible to have both hearing loss and CAPD? So in my opinion, no. If you look at, we automatically assume if you have hearing loss, you're going to have processing issues because you have a broken system. Auditory processing, as a definition, is problems in the presence of normal hearing. So again, all of our test batteries are normed on normal hearing. There's very few exceptions to that. And really our recommendations are going to be the same, or going to be, there's no point, if you have hearing loss, there's no point in going through auditory processing testing, because number one, our tests are not normed for it. So we don't really have any like good way to compare. And then two, my recommendations based on hearing loss are going to be pretty similar to auditory processing, to be honest, with it. There are more specifics for auditory processing on deficit specific, so what that child needs. But yeah, in my opinion, there are some audiologists will say yes, but our tests are not normed on it. There's really no way to say for sure. We just kind of assume you're going to have processing issues. Districts may buy some programs purchased, but I think sometimes the districts don't provide feedback regarding progress. Should we do a CAPD assessment again in order to know if the student has progressed in the areas of phonemics and auditory? So yes, I know some school districts have purchased programs that work in certain areas of auditory processing. The only way to really know if there is progress is looking at a previous eval the therapy or whatever program was done, and then a new eval. The caveat to that would be how long ago was the testing. So if it's been many, many years, there's a lot of growth that happens in the auditory system on its own. So it's hard to say, was a certain therapy successful? I mean, it'll still tell you, and a new assessment will still say what has improved or what hasn't. But you may not necessarily be able to say, yes, this therapy was successful. When you're speaking about evaluation, will this have to start with the pediatrician? This actually honestly depends on your insurance. So certain insurances do require a referral for testing. So that's really up to that I would say is really more insurance specific on if it has to start with a pediatrician. Can you talk to your pediatrician about it? Yes, absolutely. But in order to get an evaluation, it is really depending on your insurance. And a lot of times, many insurances will not cover auditory processing testing. So just kind of know that going into it. My child always asks, what did you say more than one time when I'm speaking to him? Should I be concerned? And if we should pursue an evaluation, do I request it from his pediatrician? So the big thing I would say is start with a hearing test. That's kind of the big thing, is do a basic hearing test to make sure, because you can have fluid in your middle ear and not have an ear infection. And many people don't know that. My daughter has had 2 sets of tubes. And both times she doesn't have a history of ear infections. She just had fluid that just would not leave and had to have tubes done. So I always say, start with the hearing test to make sure there's no hearing loss, whether it's something medically going on or permanent. Because I will say, I've seen a lot in my time of having to stop and not go into the auditory processing testing because there is conductive hearing loss, or I've actually even diagnosed a minimal mild hearing loss, permanent hearing loss. So the big thing is to start with a hearing test before going on. Do APD therapies must be given by SLPs that are certified? How to determine if the student progresses according to the student's grades, since many of these programs are for children and not teenagers? So speech language pathologists are all able to do auditory processing therapy. There's not really any type of certification for specifically to deal with auditory processing disorders. Usually it honestly depends on if you're talking about school system versus private therapy. Private therapy, they're going based on, you've had an evaluation, they've made goals based on that particular, the results of that evaluation, and looking at, are they mastering those goals? And then you can always do, another eval to look at, has there been progress? Also looking at questionnaires. There's some questionnaires that kind of look at, is the child, if you're talking about an older child, are they perceiving benefit? So that's kind of a hard one to say. A lot of these therapies that are out there, there's not a ton of research that shows what therapies would work for each, child, because it's very individualized. We know that things will help, but we don't always can guarantee how much they'll help. And that's with any type of auditory training, auditory therapy, speech therapy, like all of that of you're working towards, improvement in a lot of those different areas.
Real quick, before we continue with the question and answer session, I just wanted to let everybody know that in the chat is the YouTube channel for HTRAN, and the ACDD surveys in English, Spanish, and Korean. So please take the time to fill them out. It helps us by giving us feedback. Thank you.
What therapy is recommended when there are deficits in binaural integration? What therapy is recommended when there are deficits in temporal processing? So there are several different programs out there for integration. CapDots is one of them. And then there is some other ones where it is there's some iPad things that are about to come on the market that look at binaural integration, that are by some of the big name people in auditory processing. There's also Acoustic Pioneer is one that has some modules that work on binaural integration, but a lot of those are going to be more kid friendly. And then there are some free programs. There are some things that we can kind of look at to kind of teach you to kind of how to kind of manipulate an iPad on your own to kind of do some binaural integration therapy at home, some protocols that we can set up. A lot of times when we're looking at auditory processing therapy, it's all about, if you think about if you go and you tear your ACL, you have surgery, but you don't immediately walk, you do physical therapy. Kind of think of the auditory processing therapy as physical therapy for the ears. You're looking at strengthening the auditory system. And so there are a lot of different modules out there, free, some paid. There are some apps. So there's lots of different things that you're looking at. And even with temporal processing, you're looking at, again, auditory training programs that look at lots of different aspects of how you hear sound, but it's looking at strengthening the auditory system. And also music. There's lots of research that looks at being able to play music. So being able to play an instrument, so musical training actually improves the auditory system. So there's tons of research out there on that. How much does testing cost, and is it covered by insurance? So most of the time, insurance is not always covered. It's very individualized. It's very specific to your insurance policy. Sometimes it can just be a copay. For us, if you come see us, the actual auditory processing assessment is $100 for the first hour, and then $25 for every 15 minutes after that. So it can range. It really depends on how long, because it's a time-based test, how long it takes for the child. Younger children are going to take longer because they need more breaks. And older kids can go faster if they have attention. So that's specific to our clinic. I don't know about other clinics. There's not a ton of clinics in the area that do auditory processing testing. I have people that drive a lot of distance to come to our clinic because we're the closest one around to them. What can parents do to help their child keep? Oh, sorry.
Sorry. Can you repeat the last part?
Oh, that I've had people drive lots of a great distance because we're the closest clinic around that sees auditory processing disorders. So that's something to also note when you're making an appointment, is asking if they do auditory processing testing. Again, the first thing is hearing test. And then if there's normal hearing, then looking at auditory processing testing. What can parents do to help their child keep their child's hearing healthy? I notice my child speaks very loud and he loves loud noises. He is still young. really the big thing is if you're going to, if they're listening to anything with like earphones, making sure that you can't hear it. If you can hear it, it's too loud. Lots of kids are loud, young kids especially. If it's something that you're concerned about, you can always get, request to have a hearing test done. Because hearing tests are not invasive. We play games with little kids to be able to get, to test results. So the big thing is, if you are concerned, it doesn't hurt to get a hearing test, and have them wear hearing protection, if you're going to go out and do any type of noisy activity, like if you're going to one of the football games, little kids can wear, there's earmuffs that you can get. You can get them all at Academy, Amazon, kind of any of the, big name stores that have the earmuffs, or going out, any type of loud noise or concerts, anything like that. Can you share the name of the law? It's the Literacy Act. The Literacy Act was done right before COVID hit. And the literacy law was to help really try to intervene with reading a lot earlier, get kids help, get diagnoses of dyslexia done early to intervene. Some of the act parts have not been implemented. I know they paused because when the act, it was if you were not on if you were not reading on grade level by third grade, then you would be retained according to this law. I know that they delayed that because of COVID. I'm not sure when that part will go into effect, but that was delayed. Is it true that tubes actually help prevent hearing loss in a child that gets more than 5 ear infections? So what tubes do is it allows the fluid to drain. It doesn't necessarily prevent ear infections. It prevents fluid buildup, is kind of the primary job of it. With tubes, you are able to use eardrops, and eardrops can treat, a lot of times it goes into the middle ear and can treat it more directly with the tubes. But the main purpose of the tubes is to kind of get rid of the fluid. Does Auburn University provide testing for APD? Yes. So I do APD testing. I do a time slot once a week where I do auditory processing evaluations. And we have another clinical professor that has joined our faculty that is also going to be taking on, so that because it is such a need, and my time slots fill up pretty quickly each semester. So he will also be seeing patients as well. So we'll have not just me, but also Dr. Robert Melton doing testing at the clinic. How common is that students have a diagnosis of ASD, also have APD? There's really unknown, because so many times, and I've actually had, I remember a person that came and they were withholding the diagnosis of autism because they wanted me to do the APD testing. I will test a child if they have a diagnosis of ASD, but not everybody will. I am very upfront though with parents that if, first of all, they have to be able to do the testing. And if it's a global, if I'm seeing deficits in everything, then that's not considered auditory processing. That would be considered autism or something else. So I am very upfront with testing on that. They may not get a diagnosis of APD, but I'm not going to withhold a diagnosis just because of autism. It is more of, if it's a global issue, then that's not APD. So there's not really a lot of numbers on how many people have APD and ASD. There is some research out of UT Dallas that has shown that when a child that does have ASD, they're going to have their deficits are a little bit more severe than somebody that without an ASD diagnosis. But there's not really, I don't have numbers on how many that would be. My email is actually on this next slide, actually, hold on. No. Oh, there we go. So here is actually my email. And then this is the Auburn University Speech and Hearing Clinic phone number. If you are interested in, setting up evaluation, if you have questions on whether your child should be tested, you feel free, or have other questions, feel free to reach out to me. Well, thank you for the ones that have thanked me. Thank you. I hope this did help. I know it's kind of an overwhelming topic, and it's a lot of information. Even when we are counseling, when I'm counseling families on the results, it is a lot. And it is, complicated because our brains are complicated, and it takes a lot for us to process sound. So.
Maria, you're muted.
Sorry about that. I don't see any other questions, Dr. Jones, but a lot of comments about saying thank you for presenting on this topic. This was a great presentation. Thank you for explaining this topic in a simple way for us. I didn't understand much about the audiologists, but now this makes a lot of sense to me. Thank you so very much for this presentation, Dr. Jones. I do believe that it is so important for parents to continue to learn about different topics related to their child's conditions, because this specifically with this topic, it could really impact different developmental levels. And so it's so important for the parents to fully understand how does this relate to the person's ability to understand and remember information, and so with communication. So thank you so very much for presenting for us. And I would like to invite parents that if they do have a question, to reach out to Dr. Jones, or letting us know if they have a question. We'll be happy to reach out on your behalf if there is a language barrier. And we'll be sending and sharing the PowerPoint via email. So you will be receiving it, and we'll also be sharing the links for the survey. So Dr. Hill, is there anything else that you would like to add?
No, thank you for this very informative presentation. I just had a question. As part of the evaluation process at school, do they ever do auditory processing evaluations?
So with typically what they do is a hearing screening as part of the IEP process. It depends on if they have an educational audiologist. I will tell you, in the state of Alabama, there's very few school systems that have an educational audiologist. So a lot of times they contract privately. I will say I have had school systems, referred for me to do the testing, because again, most school systems in the state of Alabama do not have an educational audiologist. So most of the time, I would say if they've gotten an auditory processing diagnosis, they went privately first. But I have had school systems pay for evaluations.
That's good to know.
If there's concern. So
a parent could request that as part of the process.
Yes.
Okay. Well, thank you. This was a very valuable presentation. I think it's one I could probably watch more than once and get more information. I did want to, we all learned a lot, I think, and it's obvious you have lots of experience. I just wanted to reach out and thank our Spanish interpreters, Mr. Reed and then Miss Han and Miss Kim for Korean. And I did want to say at 6 December at 10 a.m., we are going to have one more presentation for this year, and it's social skills for the holidays. Maria, did you have anything else?
No, I just want to say thank you again to Dr. Jones. I know that, we were, kind of seeing each other, in different events. And I was like, Dr. Jones, I mean, we would like for you to present. And she's like, of course. So thank you again for your time and for sharing your expertise with us. I really enjoy it. And like Dr. Hill said, we probably will have to watch it again. And for the families that are Spanish speaking or that you speak another language, once that video is uploaded into the YouTube channel, you could select caption so that you could, the presentation, will be recorded. It is recorded in English, but you could see the translations and the captions in the language that you select. So once again, Dr. Jones, thank you so very much and for your time. And we'll be seeing everybody. Hopefully you guys will join us on December 6th for the last presentation of the year. So thank you so very much, everybody, and have a nice week.